Tamsin. Okay, well, good afternoon, everyone. So we're going to walk through. This is the agenda for the presentation. I'll take about around half an hour. We'll try to go at some speed to leave us some time at the end for questions and answers. I'm currently in on the West Coast in San Francisco, so it's a bit early in the morning here. So yeah, forgive me if I'm kind of waking up as we get into this. So we'll start with an overview of cardiovascular disease. We'll then touch on lipid encode and where we are in terms of polygenic risk assessment in relation to lipid encode, because the report itself includes a lot of other dimensions to it, which we're not sure that the current users of the report are familiar with. So we're going to spend some time going through that. We're going to look specifically at the clinical utility of cardio-encode score, which is part of lipid encode. And then we'll walk through some patient use cases and give us some time at the end for Q&A. Okay, so I just thought I'd start with this as a to set the scene. This is the NHS 10-year plan. Looking back in 2013, it had already started to recognise that prevention of heart disease and reduction in mortality in terms of stroke, heart attack was an important precedence and an important key part of the strategy for the NHS. And also it started to talk about preventative measures. As part of that, there was a goal identified to reduce or identify 25% of individuals who were suffering with FH, diagnosed FH. And that had also been part of the 2013 plan, but had been struggled to be delivered. And that's part of the reason why we're now working in the north of England with the Newcastle, Sheffield and Leeds groups. But in 2025, just in the last few weeks, the new plan is built on that. The difference now is, though, that we're starting to lag behind, whereas we were perhaps on par in some of these instances with tackling heart disease. There's now recognition that we're not in line with some of the other countries globally in this area. And importantly, this final point, we're now recognizing that the advance of prediction or prevention, and I'll talk a lot about prevention in relation to moving ahead with prevention. We have to do it on a genetic basis to get ahead of that, to identify those individuals in the population at risk, and therefore start to plan ahead. And that's where the genetics of the individual lifetime risk comes into focus. So we've seen in the last certainly couple of years, and we've been part of this process, an increasing amount of evidence, clinical evidence, around the advance of polygenic risk assessment. So this is in addition to and in conjunction with monogenic risk. So whilst most of the group may be familiar with monogenic risk for FH and the diagnosis of FH that we do on lipid encode, you're perhaps less familiar with the polygenic risk side. So we'll be walking through that in some detail today. And the important piece in relation to that is that polygenic risk assessment can be undertaken at a much younger age, earlier in life. And importantly, it can then be combined with conventional risk assessment. So that's classic clinical or traditional risk assessment. And importantly, in terms of middle-aged people, where we can then think about classifying those individuals to a higher risk position based on their genetic risk. And then that allows us to think about lifestyle change and therapeutic intervention. So today we'll walk through all of these publications that we've put out. And I'm pleased to say, one of the reasons I'm over here is we've got another announcement we're going to be making later in this week in Boston. And then at the ESC, we'll be presenting on the advances in polygenic risk. So part of this presentation will go into the Madrid ESC at the end of August, beginning of September. Okay, so let's just go back a few steps to what are we talking about in terms of polygenic risk? Well, we have our 23 pairs of chromosomes in terms of the way that we encode DNA. And within that DNA, we have base pairs that carry with them. And we're talking now at a base pair level, the building blocks of DNA and the coding for life. We recognize that some of those building blocks have polymorphisms, so what we typically call SNPs. And we're particularly interested in understanding with those SNPs, those individuals in the population. So what we do is we look at the population of individuals who have, from a case position, high level or high incidence of coronary heart disease versus those individuals in the population who don't. So back in 2008 through to 2012 as a company, and we've been doing this for over 15, 16 years as a company, GENinCode, we started to recognize and identify in the population those individuals who had a high propensity for heart disease in relation to the SNPs that they were carrying. So this was the way we built out and started to identify at a genetic level those individuals who were more likely or more probable to have an event in their lifetime. So this was the beginning of us building out what we call our GWAS, genome-wide association studies. And we published on those from 2010 onwards at a time when polygenic risk score were really not recognized. At that time, we were still very much focused on single gene mutations, cancer, and things like the BRCA gene were very popular, singularly focused in a particular area. The difference here with polygenic risk is we're talking many genes, and in the case of SNPs, multiple SNPs. But importantly, within those SNPs, which SNPs are most influential in terms of coronary heart disease? So we take that information, we then put it into an algorithmic risk score, as we call it, and then from that, we map out a distribution. So this is a bell-shaped distribution at a population level of all individuals, depending on whether they carry or don't carry SNPs of high risk in relation to incidence of coronary heart disease. And this bell-shaped curve in the bottom right, I hope you'll perhaps be a little bit familiar with that, because for those of you who've maybe had one of our reports, part of the GENinCode report, this is the way we present an individual in terms of their risk for coronary artery disease at a polygenic level within the population. So we're going to come back to that a little bit later. Okay, so let's talk a bit about conventional, or what we call traditional, conventional, or clinical risk factors for heart disease. They'll be hopefully very well known to you, typically involved in and around high blood pressure, high cholesterol, high blood sugar, smoking, and this final one was the approach by which, certainly for the last 50, 60, 70 years, whether an individual has a family history of heart disease, trying to reach through or reach back to see whether an individual has inherited risk in and around their family, which is and was perhaps the best way by which we could identify whether people carry a risk for genetic inherited risk of heart disease. And just on those, all of those have been part of the way that we clinically risk assess, whether it's the QRisk risk assessment calculation in the UK, and that's been adapted and grown over the past 10, 15 years, whether it's pool cohort or PREVENT in the US, REGICOR or SCORE in Europe. There are a number of classic clinical risk assessments, but the problem with them is they typically are based around populations that are not necessarily representative of the population that we're dealing in the current world. So they were often in the early days based on European ancestry, white European ancestry, so didn't always consider and taking into consideration multi-ethnic populations. So also they tend to be less populated by women. Certainly that was an issue as well. So there are a number of risk or issues in relation to those clinical risk assessments which have been recognised, and you often tend to find that the risk calculator can either over or under assess risk depending on the individuals who've made up that calculation. So coming out of that, we get a risk score based on a clinical risk position. And from that, we then start to think about, well, in relation to the individual, what do we do based on that information for the lifestyle and process by which we manage the patient through treatment and lifestyle? So if they have high blood pressure, cholesterol, sugar, they smoke, then what do we do? Well, it typically revolves back to everyone should exercise, everyone should eat healthily, no one should smoke. But what's become very obvious in the last 10, 15 years is that even though we have individuals who appear to have a perfect lifestyle, there is a significant proportion of them who then go on to have heart attacks. So the clinical risk equation is certainly not complete in terms of its assessment for risk for heart disease. And then on top of that, and even more recently, I think the Lancet paper in the last few weeks that was released has then further reiterated that 30% of people who do go on to have a heart attack do not have standard clinical risk factors. So we're becoming more aware that there's something else in play here. And as we go through this presentation, you'll start to see that a key part of that is the genetics of the individual. So what if we could predict future symptoms? So this is before we're seeing these clinical symptoms arise. What about blood pressure, cholesterol, high blood sugars? What happens if we could get ahead of that? So, and what happens if not only getting ahead of it, what happens if we can then go on to start to think about treatment in advance of that? So we've made some pretty good inroads, one of them being imaging. Imaging certainly has allowed us to get a better insight into risk assessment for the onset of subclinical and atherosclerosis. So that's been helpful to us with calcium scores and CT angio. But it's still very much at a point in time when there's already a presence of atherosclerosis at which that becomes most effective. So what if genetics could present and predict a future patient risk? So we'll go over now to what we currently do with the North of England in the NHS. And we start with our GENINCode report. And the report itself is made up of, there's actually 5 parts to the report. There's the bit that is typically used by the North of England NHS, which is the monogenic piece. But then there's also a polygenic LDL piece, which has increasingly become popular. Certainly in the North of England. It isn't across the country, but it is in the North of England. We then also have a polygenic CAD piece, which is the bit that we're going to focus on today. We also include predisposition to Lp(a), and we also have a pharmacogenetic piece as well. So within that, you'll hopefully be familiar with this summary report. This is the first page of that report, where it presents an executive summary and gives the teardrops, as we call them, with color coding, so you can get a quick glance as to whether the patient is at risk in relation to any of those 5 areas I've just mentioned. And specifically, it tends to have been because of the focus on FH diagnosis and the importance of identifying those individuals in the population who are at risk of atherosclerosis, accelerated atherosclerosis from FH. The FH piece of this report has been the main focus for most of the group, I think, to date. But today, we're going to talk about the polygenic piece of it, and it's the bit below this in terms of the report, this piece here. Within that bit, there are 2 parts to it. There's the polygenic LDL piece, and then there's the polygenic CAD piece. We'll probably have another webinar on the polygenic LDL piece, because again, that in its own right requires quite a bit of focus and time. But for today, we're going to focus on this polygenic CAD piece, because for us, it's a very important measure. And it's increasingly, we're going to be publishing in the next few weeks another big chapter in terms of the importance of it in relation to its modulation of LDL. And we'll touch on that towards the end of this presentation, the way in which your polygenic risk score modulates LDL. And we'll talk through what we mean by modulation and what we mean by an individual who has a level of LDL as an absolute level and measure. That in its own right, as a single point, may not be representative of the risk associated with that patient, certainly not based on clinical measures. So we'll talk through that in some detail. And then, so coming back, we're now going to talk about in more detail what we're doing on the coronary genetic risk, the GENINCode GRS piece. But just so that the group are aware, this is part of your GENINCode report. It is available on request, so you can call it off. It doesn't cost any more to the NHS. And this is another piece that we're particularly keen to do, is make sure that we deliver our testing to the NHS at half the price that they currently just do the sole FH testing for, but to include all of these other aspects. So I'm particularly keen to make sure we keep this not only cost reduced compared to what is currently undertaken, but also importantly, it's providing a much more comprehensive risk assessment in the clinic. Okay, so we're going to focus now on CardioEncode, and I'm going to talk through. So what's the clinical evidence for this CAD or coronary heart disease polygenic risk score? And you may have seen, I think Tamsin circulated this. There are four areas, or some of them are publications, some of them are abstracts, but will become publications in the near term. And we're going to walk through these, each one of them, just to make sure that everyone's up to speed in terms of what they mean, and in terms of clinical assessment, what that can mean for your patient population. So starting with this is the first main paper we put out about 18 months, 2 years ago. We typically we're always trying to work with multi-ethnic populations of patients. So this is just over 63,000 patients over a 14-year follow-up. So a significant study. We undertook this work with Kaiser Permanente here in the US, and that's why I'm here in San Francisco at the moment. I've been with them for the past few days. And what it shows is what we did was initially from the work we'd done back in the GWAS days from 2010 to 2014, we'd identified those SNPs associated with coronary heart disease. We then started to take them up into different subgroups of populations. And in this study, this is on the multi-ethnic population. So typically European ancestry, African American, Hispanic, Latino, Asian. And you have to be operating at a population, a high volume of patient level. Otherwise, the powering statistics, we can't get to the level which we want to get to know that this test is applicable across all ethnicities. And that's a key part of building out the process by which we assess risk in the population. So what this study showed was that the first point was you'll see on here, it's broken into, on the right-hand side, you have the assessment of low, intermediate, borderline, and high risk based on clinical risk assessment. And then in red bars, you have the high polygenic risk in relation to the individuals who are currently classified within there. So you can see within a low clinical risk, whether they have low polygenic, intermediate or high polygenic risk score, whether in borderline, low polygenic all the way up to high in red, and similarly for intermediate and high. And what we showed in this study was that the first point, that the PRS is independent of clinical risk. So that in itself means that because it's independent, it's additive to clinical risk. But what we also saw was within those clinical risk categories, those individuals with the highest polygenic risk score were those most in need or most at risk in terms of incidence of coronary heart disease. So this was the beginning of us differentiating the clinical risk categorization into those individuals who have a high polygenic risk, and then importantly, having identified them, focusing treatment on those individuals who need it most, those who are in those red bars at high polygenic risk. So this was the first paper, and what it also went on to show, and it's now become part of the scientific statements from the ESC and the ACC, is that you can then use PRS to upclassify individuals who, especially within that borderline intermediate group, where they typically may not be on treatment, you can start to think about upclassifying them for treatment based on their polygenic risk score. And this is particularly important when we have, for example, on the LipidEncode report we talked about a little earlier, where you have an individual who is maybe not FH positive, but maybe FH negative. They may not have a high polygenic LDL. But if they're showing up as a high polygenic risk score, then there is a significant concern for this individual on a lifetime risk for an event. So this was the first paper we published about 18 months ago based on 14 years follow-up, and we've been working with Kaiser for just over 15 years now. So this was the first paper that we published 18 months ago. This second publication was presented at the ESC last year, I think, and also part of the similar cohort from Kaiser. And again, importantly, what we're looking at here is a large population of patients who, and in this instance, in relation to lifestyle, what we were looking at was, what about those individuals then who have a high polygenic risk score within the population? And when they follow an improved lifestyle, so that is reduced smoking, improved diet, and improved physical activity, how much reduction in risk in terms of event reduction, incidence of coronary heart disease, can we see by them changing their lifestyle? And what we saw was there was a significant reduction, most significant for those individuals who had a high polygenic risk score. We could see a reduction of 52% by individuals who move from an unfavorable lifestyle with a high polygenic risk score to a favorable lifestyle with a high polygenic risk score. 52% is significant. And on top of that, not only that, by focusing treatment on those individuals who have a high polygenic risk score, you can reduce the numbers needed to treat to avoid an event. So it's the most effective way of treating the population, finding those individuals at high polygenic risk score who are most in need of treatment and focusing treatment on them. So again, this paper, a significant step forward in recognizing that polygenic risk, in addition to clinical risk, is a key factor and a factor that needs to be considered. This third piece, this is going to be, there's going to be more on this in the coming months because we've got another publication coming. But this is an abstract that, again, we presented at the ESC last year. And the importance of this is back to the earlier point I mentioned about the way we clinically assess LDL. So you'll see on this chart, you have, again, low, intermediate and high risk individuals in terms of polygenic risk score. But importantly, you've also got on the x-axis the LDL-C measure. So you can see the standard measures of above or below 100 milligrams per deciliter to above 190 milligrams per deciliter in terms of individuals who have a low, an intermediate or high polygenic risk. And what you see, if you take, for example, the low polygenic risk, and an individual, let's say for those individuals at below 100 milligrams per deciliter, and compare that to the same or an individual who has a similar below 100 milligrams per deciliter, but who has a high polygenic risk, you're looking at an incidence of coronary heart disease that nearly doubles. So again, it's really important that we recognize not only the LDL-C measure for the patient, but importantly, the polygenic risk associated with that patient too, because simply looking at an absolute measure of LDL-C doesn't give the full risk picture. And we'll come towards, when we come to the end of this presentation, we've got some patient use cases where you can start to see the impact of that for those individuals where typically they may appear to have what is a relatively low or a lower than high, not a high risk LDL measure, but even at the lower risk LDL measures, if they have a high polygenic risk score, that's still a high risk patient. So you need to be aware of those patients. So again, what we've started to talk more about is that even at levels at 130 milligrams per deciliter, if their patient has a high polygenic risk, then that's an important factor that needs to be taken into consideration. And then the other paper that we published, which was more around a little bit back to the question over family history, what we also found was that there was a really useful correlation between when you ask the patient, do they have a family history, and also they have a high polygenic risk score, then you start to get significantly higher risk of an event based on that polygenic risk score coupled with the family history. And as you might imagine, when you ask the patient whether they have a high family history of heart disease, it's a bit sketchy, not always not always easy for them to understand or recognize their, all of their family details. But coupled with a polygenic risk score, it brings a lot more accuracy to that assessment, and certainly in terms of the accuracy and the likelihood of an event for those patients with a high polygenic risk score. So you're getting a significant increase in hazard ratio on the basis of including a polygenic risk score alongside family history. Okay, so just to summarize, what we've done then is we've just quickly started to see that we can identify patients at risk earlier in life. This is on the basis we're looking at a non-modifiable risk factor, which is your genetics. To look at that earlier in life, we can start to see the likelihood of an individual having an event later in life. And again, it's a clinical decision and it's a physician decision as to when they decide, when you decide you want to look at that and how early you want to look at that. But importantly, you can also identify high-risk patients undetected by clinical risk assessment and then consider up classification of the clinical risk based on that polygenic risk. And then we're getting into prevention then, where we can recommend more effective and timely prevention treatment. So what we're doing here is using genetics to enable prevention before the symptoms present. And post, if it's then obviously if the symptoms are already evident, because we can see that the patient's suffering with heart disease, well, then it becomes more of a diagnostic and a recognition based on the genetics that the individual has FH or is at risk based on their genetics. So all of this information, this is another dimension, another piece of the GENinCode report, which we want to make sure is being used, because we haven't had too many requests for the GENinCode piece, and we feel that it's a bit that's missing, which we hope that, on the basis of this webinar and other further publications we'll be making, that physicians become more aware of this as part of their risk assessment. Okay, so let's just move on to, and this is now moving a little bit more detail now around, well, how do we use GENinCode, the CAD, coronary heart disease risk assessment, in the clinic? So this is the bell-shaped distribution, and in blue at the bottom there you can see where we typically report a patient. In this instance, is patients in the what we call quintile 5, the high genetic risk quintile. So it's broken into 20% quintiles, and the upper 20%, the high genetic risk piece, this individual has a score of just over 1, sits pretty much in the middle of that high genetic risk. But importantly, as the patient moves further to the right, then their risk of an event increases. We'll see that in a moment as we talk through some of the hazard ratios. But importantly, as they move into that slightly darker shaded red, that level, once you get up to the higher tail end, is equivalent to an individual who is at risk, at the same level of risk as an FH heterozygous patient. Now that, again, totally independent of monogenic for FH, totally independent of LDLC. All of these pieces we're talking about are additive in terms of risk. And this CAD PRS piece is additive as a risk factor alongside monogenic and the polygenic LDL piece. So the way we've built out, the way we've put our reports together, and the way we've constructed over the last 15 years is this is incremental and additive in terms of risk to clinical risk assessment. Okay, so who should be tested? Well, we typically would recommend that this is the groups that you should be thinking about. Certainly middle-aged patients, especially those that we talked about in the borderline intermediate risk, with cardiovascular risk factors, but perhaps in that intermediate range. Patients with a family history, as we've talked about, but where they have a family history, then it's really important to test at a younger age. And as we talked about a little earlier again, patients at borderline LDL-C, this is now, we're talking between 130 and 160 milligrams per deciliter, not up at the higher levels, especially where lifestyle and other traditional risk factors appear normal. And then again, down to the younger or healthy patients interested in their personal lifetime risk. So this is the group that we would see being prime for testing. So what about communicating to them? Because a key part of what we're talking about here is educating not only ourselves, but also the patients. Well, we typically would communicate the role of genetics in explaining to them what it means alongside their clinical risk. We distinguish that these are PRS, which are clearly common variants, but the sum of those variants can have an influence over their risk. So they're not rare, high monogenic risk, pathogenic risk variants. They tend to be much more common and carrying a smaller pathogenicity. But depending on which variants are used or SNPs are used, then obviously they coalesce to create a much higher risk based on a PRS calculation. Discuss the possible results. Again, not the elevated or high ones, but you should certainly discuss the results with the patient and explain to them what it means. And then how those results, based on those results, how it can then impact prevention planning with them. Okay, so just to start to think a little bit about then clinical utility, how would this then be used? So as we've said, it's leading itself into much more lifetime risk earlier in life, and the ability to treat earlier based on that risk. And for me, that's really important in terms of that prevention piece. If we're truly aiming to be ahead of the curve in advance of symptoms arising, then this is the route path or one of the routes into preventing at an earlier stage in life. So coming back to the Q risk process, so is the patient older? Then I think it's a 25-year start point at the moment for Q risk 3, I think. And therefore it would be used as a risk enhancer to what you're seeing at a Q risk level, and then you can recommend lifestyle change or the initiation of therapy treatment or more aggressive treatment, depending on the risk of the patient. Or in the case if the patient is older, if they're not older than but they do have a high LDL-C, then clearly calculating the CAD-PRS is an important risk factor in addition to that. So they're just the two main routes to using PRS, CAD-PRS as a further risk enhancer to current clinical risk positioning. So this is the way that we typically describe it. Some of you may have already seen this. So this is the typical clinical risk assessment. So whether you are lower than a 10%, 10 to 20%, or above 20%, and therefore you're high risk of an event over the next 10 years, based on the Q risk calculation, what we do is we run against or alongside that the polygenic risk score. So the individual may be low, intermediate, or high. And if they have a low clinical risk and a low polygenic risk, then it will be more a case of maintaining and observing on a routine or a periodic basis, perhaps annually, emphasizing the lifestyle changes that we talk through. If the patient has got, though, the borderline, intermediate, or moderate position in terms of their clinical risk, and they have an intermediate genetic risk, well, the physician can consider whether they onboard them or classify them depending on their clinical risk and genetic position, especially depending on family history. It's an important consideration. But the easiest ones to spot are obviously those who have a high genetic risk, especially where their clinical risk is at that moderate or borderline level. So we typically would recommend that where they have a high genetic risk score, that you consider action, whether that's initiating treatment, and certainly further educating the patient around their lifestyle and enabling them to try and aim at a preventative strategy. Okay, so what we've done now is I've just put together a couple of cases, and what I'll do is I'll probably introduce Marta at some point, but let's just start with this first one. So this is a patient, female, 35 years of age, with LDL of 195 milligrams per deciliter. Father passed away at 40 due to a heart attack, and a paternal aunt in Italy had a quadruple bypass at 50. So all indicators are that this could be a high-risk patient. A primary care physician refers it to genetics, whether that's the GLH at Newcastle, or then onwards to ourselves for panel testing for FH. We go through the FH testing, and they're all negative. It's not uncommon. It's pretty common, this. We see a lot that are negative. But we also then often see that the patient has a very high CAD risk. And in this instance, the earlier example we talked about, this patient is now in that high risk area, that slightly darker shaded red, and that is the equivalent risk to a heterozygous FH patient. So at first sight, the patient may look to be not at high risk because they're FH negative, but in this instance, this patient is at high risk. So, and it's these patients that we are particularly keen to ensure that are being recognised and are not being missed in amongst your risk assessment. And like I say, this information is available in the GENINCode report. Okay, so that's the first. Marta, did you want to add anything to that? I don't know whether you're on speaker. Did you want to add anything to these comments that I've just made?
No. It's fine from my side.
Okay, so then let's talk about, we talked about the modulation of LDL-C. This is really perhaps a big piece of change that I think is coming quickly, and we want the NHS physicians, and bearing in mind, I mean, we've worked really closely with Pete Carey, Ahai Luvai, Stuart Patman, the EMA, Julia Newton at the HIN. I'm trying to wrap my brains as to some of the other people who've really been close to us over the last couple of years as we've implemented what we've done. And this for us is a really important recognizing piece for the way you think about LDL-C moving forward. So what we have here is, this is a 47,000 population of patients. Again, divided up into LDL-C levels within those patient groups, and then categorized in terms of low, intermediate, or high polygenic risk score. So there's the low, there's the intermediate, and there's the high polygenic risk score. And what you see is that those individuals who, like we said earlier, they have a low, for example, if we take the first row at the top there, they're below 100 milligrams per deciliter of LDL-C, and they have a low polygenic risk score. And we use those as the reference in this instance. And then upwards from there, you can start to see how the hazard ratio changes based on their polygenic risk score. So if we then jump to the high polygenic risk, and at the bottom third of this chart, you've got on average a 1.75 increase for an individual who has a similarly below 100 milligrams per deciliter LDL-C, but you're getting close to doubling the risk of an event based on that. And what we're seeing now is that the polygenic risk is modulating or amplifying the risk of a patient for an event. So this is a really important piece, this assessment alongside LDL-C as a clinical measure. So let's take an example of how this then runs on a patient case. So female, 45 years of age with a family history of coronary heart disease, LDL-C in this instance, 152 milligrams per deciliter, smoker and overweight. The team pursues a polygenic risk score test, whether it's done independently, and we GENINCode we do as a standalone test, but in the case of GENINCode, like I said, it's included. And in this instance, this patient has a high polygenic risk score. So in this instance, for this quintile 5, where this patient is at twice the risk than they would perhaps be if we weren't looking at the polygenic risk. So this is a risk enhancing factor in this instance. So again, the physician team can start to consider that increased risk and whether that may mean more intensive or initiation of therapy, depending on where the patient is. Marta, any comments on that?
No. Just the importance of polygenics in evaluating the real risk of coronary heart disease by the same level of LDL cholesterols and the wide range of you can found depending on your polygenics, and how polygenics also can explain the heterogeneity, between same level of LDL cholesterol but different endpoints.
Yeah, exactly. Okay, so
Matthew,
so that's it.
Sorry, Dr. Chandray has got a question.
Okay, yeah. So I'm coming to the end now, so that's fine. If we can kind of open it up for questions, because I won't go through this summary, and it's pretty clear. I think we're coming to the end now, but this is a summary of where we are. I'll leave that summary up if you want to ask a question.
Dr. Chandray, did you have a question?
Yeah, can you hear me, please?
Yes, I can hear you now.
In regard to the previous patient, 45-year-old, what was the Q risk, JBS3, in this patient?
Well, I don't know. We'd have to look. We do not see those Q risk calculations. We work totally independently of those. So you would have to look at the clinical record for that patient, Dr. Chowdhury, to get that. One of the things that we're starting to do with the team I mentioned a little earlier is start to consider how we can look more closely at the clinical records Q risk, as you've just said, alongside the genetic risk that we're identifying here, because what we can see is we're reaching through knowing that this patient is at risk, but we don't have all of the insight to their clinical and medical records that you have. So it's an important question you raise, and it's one that we think we need to work more closely with you on.
Okay, thanks.
Yeah, if I may, in order to calculate the Q-risk, we will need further clinical values that we are not requesting for GENinCode. For GENinCode, we are just requesting LDL cholesterol, total, whether you're in statin, whether you're in treatment, if there's a family history, but we are not requesting all the other information that it's needed to calculate the Q-risk.
So that's something we could move to, again, with the NHS. And I'm particularly keen in the north of England to keep the group at the forefront of all of this. And if we need to do that, that's something we can look at doing with the group. We've already moved to providing online access to everything we do. We've implemented the changes in our reporting so they align with the NHS standards. Obviously, all the reports are UCAS based. But yeah, that's something we can start to think about. We've talked to, I know with Pete Carey and Ahai and the rest of the team about thinking about more clinical assessment, especially for these patients where we can see they're at high risk, but we don't have that insight, Doctor, at this point.
We have another question from Dr. Alawatu. Apologies for my pronunciation.
Yes, thank you. Thank you very much. Now, from the answer that was given to the issue of the Q risk now, do we then assume that the use of PRS will be a flow through from the request from the genetic testing? That is, when we have the result of the genetic testing, this other PRS would be part of the report that we get. Then we then take it off from there, whether it was positive or negative. And when it is negative, we then assess the PRS to make the final decision whether the patient would need intensive treatment or otherwise.
Correct. So it's definitely a flow through. Like I said, it's part of the GENinCode, the 5 dimensions. All of them are available to you, but at the moment you have to request them. So it's important that we can see that there are patients with high CAD risk, but what we don't know is whether you're requesting them or not. But from what we can see, we don't think that you're requesting them. So I'm worried that you're not getting the full utility of everything we've just talked through. It's all there in your report, but you need to request it. So the flow through is there. And obviously part of this presentation is to make sure that we bring you up to speed with the importance of this as a new risk factor.
Dr. Levi, I think you're next.
That's really good presentation, and some of your graphics are really good. The interaction between high LDL cholesterol and cardio in score is really good to see. Of course, I think we've talked about this before. Most of our patients will be in that 190 milligrams per deciliter and above because they are selected by Simon Broom and so on to have the genetic test, and then they get the cardio score. And we know now from looking at that data that their risk will be doubled over where it would be from the LDL cholesterol alone. So they are ultra high risk patients. The one thing that I just wanted to point out about the first case is that patient, even though their genetics is negative, we would still consider them high risk because of that strong autosomal dominant family history. Of course, the polygenic risks don't actually explain that autosomal dominant pattern. So we always want to be careful in case there's an undisclosed mutation in the family with FH.
Absolutely. No, remember, I mean, just to be clear, in conjunction with monogenic. It's always in conjunction with. I agree entirely with that. The thing is, at the moment, there tends to be a little bit, in our view, whilst we've now got polygenics coming up on the rails, there's still a little bit too much focus only on monogenic, whilst we've now got clearly strong clinical evidence of the importance of polygenics.
Yeah, no, you've got to look at all the evidence you have and put it all together to make a personalized decision. So and this is taking us in that direction. So the other thing is, in the Northeast, we've always had the LDL SNPs, but we are kind of doing them illegally because they're not in the genomic test directory. And then the cardiogenic PRS is also going to be another illegal thing because it's impossible to get anything on the genomic test directory. What strategies do you have in place to kind of get around that problem?
Well, I mean, again, it's interesting when you say that. I mean, for me, I just go, let's say route one high, and that is that we need to get it on the test directory. So, let's be clear, the evidence base we're building, not only the figures and the publications I've walked through, but locally, you now have, I'll just put it up because I put it at the very end here. This is a summary of what we've done in the last 18 months, 2 years with the North of England. We've done over 2,500 lipid encode tests. They've been delivered at, on average, around about 15 days from sampling to report out. We are providing, as you know, a comprehensive risk assessment, not just the FH piece of that, at half the price for just the FH only, the NHS piece. So for me, we carry on doing what we're doing. We keep building out the evidence base and strengthening where we are. And we get the test directory to include what it should include over time. And that's not to suggest it can happen immediately. But I think we make our case, make it carefully and clearly, and move that forward. But in the meantime, you as physicians, we just want to make sure that you are right at the forefront of knowing where some of these advances are, because they're there, available to you. And I am, for one, concerned that we're not really, well, that whilst they're available to you, I wonder whether they're actually being used in the way that we've just walked through.
Dr. Furat, I think you're next.
Yeah, no, all a very interesting conversation. I was interested in Deepak, you asking about this. So I was involved in the PI for a study called HEART, which was done with Genomics PLC. But we took 824 patients between 45 to 64 coming for NHS health checks. So this is very much primary prevention. And we integrated the polygenic risk score with the Q risk. Now, it was QRISK 2 because that's all we had in our systems. It was a shame we couldn't do it with QRISK 3. But what we found was that there was, in 24%, there was a clinically significant change in their CVD risk by adding a polygenic risk score. And that then led to either lifestyle changes or, in many cases, patients going onto a statin when they would not have gone on a statin just with their Q risk. So I think I think this is truly primary prevention, and that's where I personally see a lot of this polygenic risk score playing out, and I would love to see it included in the assessment of primary prevention patients, ideally alongside a one-off Lp(a) test. And I think these are different to the population that many of you, of my esteemed colleagues, are seeing through your lipid clinics, where you're having patients referred who either have FH, or if they don't have FH, they may have polygenic hypercholesterolemia. But if they then don't have either of those, we should be looking at the PRS, the polygenic risk score, to then optimize therapy. So I think it all should all be looked at in a holistic manner, sort of combining primary, secondary prevention, and that I think would be the ideal goal. I mean, some of you may disagree with that. Some of you may think it's not achievable financially within the NHS, but until we have that, we're not really going to be cutting the risk of cardiovascular events, in my opinion.
Yeah, well, and just Ahmet, I apologize. So I should have mentioned you. You've been instrumental. You've been instrumental amongst that list of names I mentioned earlier in terms of support and help. I fully agree. What we've done in this presentation is just covered off two areas. One is the GENinCode more higher risk patient grouping for familial hypercholesterolemia. But in addition to that, the GENinCode standalone PRS piece for primary prevention is such an important piece. And again, just to be clear with everyone, we're talking about a low-cost test for once in a lifetime that goes on your medical record, and the value of it in terms of future lifetime risk and prevention is so important. The payback in terms of investment in a one-off test, I don't think it gets much better. Okay, so
Sorry, Matthew, Marta's just got something to add.
Sorry,
yes,
Marty.
I just want to add that we have done 2 pilot studies in Spain. We use not CURIS because it's for UK, but the RegiCore, and we have also combined the GENinCode polygenic risk score with the RegiCore, which is an adaptation of the Framingham risk score for Spain. And we have found almost the same figure that you have just said. Around, depending we have done 2 pilot studies in 2 different areas of Spain, in Catalonia, which is not finished yet, and in central Spain, which they have a high rate of cardiovascular disease because they have a high rate of cardiovascular risk factors, and the values are very similar, from 50 to 20% of patients when adding polygenic. Those are primary prevention patients, middle age, and we took only moderate risk by RegiCore, not low, not high, moderate, to see the value of a polygenic risk score in that subgroup of patients, and from 15 to 20% of patients by using the polygenic risk score are up classified to a higher category. So you could start studying a treatment, focus, lifestyle recommendations. We are now, at least in Catalonia, following them. We are in 6 months following, and we have done a review of what is happening with those that have been reclassified, and the follow-up is quite good, because in general, most of them are reducing their the values of the risk factors, and also by, again, combining polygenics with their new risk factors, they are reducing their cardiovascular risk, whether the 10%, the value of the risk of the percentage to have a coronary heart disease in 10 years, but also by being reclassified from moderate to low. So we are getting quite positive and results. So just wanted to add this.
Thank you, Martha. That's wonderful. Have you published that yet, or
no, not yet.
Not yet.
Not yet, because we will be ending the follow-up, 12-month follow-up, by the end of the year. So next year we are planning to follow up. Now we are in the 6-month middle term follow-up, but follow-up would be 12 months at the end of the year. But the results independently, whether we are focusing in Catalonia or in the middle Spain, the percentage of reclassification is It's very similar, from 15 to 20%. But then if you add those patients that don't reclassify, but are very close to reclassify, so if they just, sum up 1 or 2 years or worsen their cardiovascular risk factors, they would be rapidly reclassified to a higher category. Or you also take those that don't reclassify, are not very close to reclassify, but you are identifying a polygenic risk score, and in those you could start, even if they don't change category, you could focus on lifestyle, tobacco, overweight, and those kind of things more strictly. It's 30% of the population that you are adding clinical utility.
Fabulous.
So it's quite interesting.
Interesting. Will you be at the ESC in Madrid, Marta?
I'm not sure I will
Okay.
be.
Well, if you were, we could meet up for a chat. I love Madrid.
Yes.
Thanks,
if I go, I will.
No. Listen, we will be. Some of the team will be there. So if you're attending Armet, stay in touch, and we can catch up while you're there. So we've come to the end. I'd just like to. I've just thought of a couple. I'd also like to just say quickly. I'm not sure whether they're on the call or not, but to Angie Silman and Kieran McAnulty, thank you to them too, because they've also been instrumental to delivering what we've done over the past couple of years. And I don't want to not mention them. I think that's it. I think we're out of time. Tamsin, is there anything else that we need to do in terms of? And there goes the phone. Anything else we need to do?
I think Ahai's just got a one last point.
Sure.
Yeah. Ahai.
Matt, Tamsin, is there a plan to share the 2,500 Northeast data, in a bit more detail with us, please? I think that's really, really valuable.
Yeah, certainly. I think we need to book another meeting now, Ahai, and then we can start looking through the data for those 2,500. It's now 2,600, I think. So no, we can certainly pull that data and start looking at the CAD PRS and so on and so forth. Certainly, I'll come back to you on that, Ahai. And just to say as well that we're obviously I'll circulate the recording as well. So if anybody wants a copy of the recording that's here, do let me know, and I can circulate you a copy of that as well.
Wonderful. Thank you, everyone. It's great to see you all. Let us know if you have any further questions, and we look forward to staying in touch. Take care. Have a great day.
Thanks,
Thank you very much, everyone.
Bye-bye.
Bye.